So this patient gets a scope. This is just, remember, they're coming in for just a GI bleed and they have cirrhosis, and we talked about the areas where you can have portal hypertension. We can have esophageal varices, capita medusa, and internal hemorrhoids. They get a scope and they turn blue. All right, so they get a scope and turn blue. Now let's go to the board review question on that. Remember, this is not a fair question because it's a board review question. Which of the following is the most appropriate next step in management? All right, intubation and mechanical ventilation, IV administration of methylene blue, exchange transfusion, high-dose corticosteroids, and hemodialysis. This is a 34-year-old male presented in the emergency department with acute onset of cyanosis, headache, shortness of breath. He recently underwent a dental procedure and was given topical benzocaine. Now, we're going to say why this question is wrong. The answer is right, but the clinical scenario has an error in it. Let's talk about that. On examination, he is tachycardic and his oxygen saturation is of 85% on pulse oximetry, which does not improve with oxygen. So he does not improve with supplemental oxygen. So something is going on. Arterial blood gas analysis results in a PO2 of 98 millimeters of mercury and a calculated oxygen saturation 98%. His blood appears chocolate brown. So chocolate brown is probably giving us too much information. Why this information, why this it was a little bit off is that when this patient received the dental procedure with topical benzocaine, this probably would have happened immediately. I don't know if he would have been able to get to the hospital in time with this presentation. Usually it happens pretty fast. So what are we looking at? What's the answer? The answer is administration of methylene blue. So what was going on here? What happened? So this patient went to have a scope. This other patient went to have a dental procedure. Both of them were given topical benzocaine. And what happened? So they became hypoxic, immediately hypoxic. They had chocolate brown blood. And we need to give them methylene blue. So what is this? Acquired methylhemoglobinemia. So what happens is the ferrous, which is normally F2, ions of heon, oxidizes to ferric state. So ferrous to ferric. The ferric state is unable to bind to oxygen. You have oxygen dissociation curve is shifted to the left. So what can cause this? Medications such as dapsone. When do we use dapsone? Dermatitis hepatiformis. We can also associate with celiac disease. Remember, we need to check a hemoglobin. We need to check a G6PD for deficiency before we administer this medication. And when we have a G6PD deficiency, do you remember what we're going to see on our cells? We'll see Heinz bodies and bite cells. So we're kind of getting all these things together. Is this patient comes in for a GI bleed, have cirrhosis, have a scope, they spray some benzocaine prior to him, and he has acquired methylhemoglobinemia. Other medications that cause it could be dapsone, and let's pull up what dapsone could be is for dermatitis hepatiformis. Can be also used associated with celiac disease, which dermatitis hepatiformis is associated with celiac disease. Before we give dapsone, we need to do what? We need to check for G6PD deficiency. G6PD deficiency, we would see Heinz bodies and bite cells. Now, continue medications, the benzocaine that these patients received, lidocaine, prilocaine, inhaled nitric oxide. So let's go back real quick. This patient received this, had acquired methylhemoglobinemia, and became hypotensive, also hypoxic. Acquired methylhemoglobinemia, signs and symptoms, cyanosis with pale gray or blue colored skin, lips, or nail beds. Can have headaches, tachycardia, dyspnea at higher, and when you get to higher levels. And even extreme levels, you can have respiratory depression, coma, seizures. You're gonna have a normal arterial PO2, and then you may get lucky and see this chocolate brown blood. What's the treatment? It's methylene blue, like this patient received, 1 to 2 milligrams per kilogram over 5 minutes. Avoid, if known, G6PD deficiency, and you would give them ascorbic acid. So here again, a patient coming in for a GI bleed, cirrhosis, gets the scope to give them benzocaine, and has an acquired methylglobinemia, we would give methylene blue. If the patient has a known G6PD deficiency, what are we going to see on their Heinz bodies and bite cells and G6PD deficiency? We would give ascorbic acid. All right, so this young lady who came in, 54-year-old female, unfortunately, we had hyperlipidemia. Unfortunately, she had a bad side effect to atorvastatin, and then rising in the hospital confused and was intubated. Now she's not doing well. She's not moving at all. Her pupils are 12 millimeters, not reactive. Just for a baseline, normal pupil size is going to be anywhere from 2 to 8 millimeters. And remember, not everybody is perfect, so everybody coming in the door is going to be perfect. So you'll have some 10s that are normal. Hers are huge, okay? And what's the reason why? Is ammonia, remember she had the hyperammonia levels. Ammonia exposure can cause the astrocytes in the brain to swell. Astrocytes are about 1/3 of the brain. And we concern about it mainly in levels of ammonia levels 200 to 300. Now, we have this helmet here, and cerebral edema is pathological accumulation of fluid within the brain, parenchyma. It can increase our intracranial pressure. It can cause compromised cerebral perfusion because you're pressing the brain in, and leads to potential herniation because you have this helmet here, you're pushing against the helmet, and you have to worry about the brain herniating in. Medical treatment of elevated intracranial pressure. So this lady has come in, and now remember, she just didn't read the multiple choice question. She has multiple things going on. She can give mannitol. You can administer this at 1.5 to 2 milligrams per kilogram IV over 30 minutes if imminent decline is suspected. 0.2 grams per kilogram every 6 to 8 hours. Hold of serum osmolar greater than 320. Repeat doses is associated with rebound cerebral edema. Can cause a kidney injury. That's why mannitol is kind of going to the wayside, and now the 3% is hypertonic saline is being used more. It's first-line treatment. It's a volume expander. It can also be used if the patient is hypotensive with an elevated intracranial pressure. Now, you can use 3%, but if you're really getting to where you feel this patient is going to herniate, you're going to throw your bomb pass. You're fourth down and you're at goal and you're trying to score, you're going to use a very high concentrated 23.4, giving 20 to 30 milliliters. This is, you suspect this patient is going to herniate and you're trying to stop the herniation. And then if you use 3%, you want to get a target serum sodium level of 145 to 155. Hyperventilation on the ventilator, not used much anymore. And what's this is trying to get a goal. You're getting rid of the CO2, and you're trying to get a goal. Remember, normal CO2 is roughly about 40, and if you need a PCO2 to 28 to 35 millimeters of mercury. Short-term stabilization, but associated here again with rebound elevated intracranial pressure. All right, a 36-year-old male presents with symptoms of abdominal pain, jaundice, pale stools, diarrhea, and weight loss. Now, jaundice it's yellow discoloration of the skin. Where can you see it the best? Best place when you're looking at a patient, mucosal membrane. It usually becomes apparent when the serum bilirubin exceeds, we'll say 3. But the best place to look, first sign, you can pull down and look in the eyes, but best side is looking up in the mucosal membrane. Remember, bilirubin is a breakdown product from hemoglobin from red blood cells, and is processed in the liver and excreted into bile. Jaundice can be classified 3 different ways. This can be prehepatic, intrahepatic, and posthepatic. Prehepatic can be from hemolysis, excess breakdown of red blood cells. Intrahepatic, impaired hepatic uptake, could be due to hepatitis, drug-induced liver injury. Posthepatic is obstruction of the bile flow, choledocholithiasis, or malignancy. All right, let's get to another fun and exciting board review question. Remember, it's not fair because no board review question is fair, and we're trying to get information into our brains so we can do well, take care of patients, and pass our boards. And what is the following is the most appropriate next step in management? So we're looking next step in management. Initiate high-dose ursodeoxycholic acid. Refer for liver transplant. Begin immunosuppressive therapy. Endoscopic evaluation of the dominant stricture. Surveillance for cholangiocarcinoma and colorectal cancer. So this is a 38-year-old male with past medical history. This is important of ulcerative colitis, presents with fatigue and pruritus. Laboratory studies reveal elevated alkaline phosphatase and mildly elevated transaminase. MRCP demonstrates multifocal strictures and segmental dilations. Here we go. Intrahepatic and extrahepatic bile ducts. This is consistent with a beaded appearance. Beaded appearance. They didn't have to give the beaded portion because the beaded kind of gives it away. But important is intrahepatic and extrahepatic bile. So what's the answer? We're going to surveillance for cholangiocarcinoma and colorectal cancer. Now, you may have thought this would be the most wrong answer, is ursodeoxycholic acid. It doesn't do anything. It doesn't do anything for what we're talking about is primary sclerosing cholangitis. It doesn't do anything. Now, we're going to talk about two diseases, and they look very similar, and this is where learners get confused. We will break it down because we're going to have a nice chart that's going to break it down for us so we don't get confused between the diseases. But ursodeoxycholic acid is not good for the treatment of primary sclerosing cholangitis. Let's talk about primary sclerosing cholangitis. It's a progressive course of cholestasis with inflammation and fibrosis in, here it is, intrahepatic and extrahepatic bile ducts. There it is. There it is. That's how we get that diagnosis. May lead to cirrhosis, portal hypertension, end-stage liver disease. 75 to 90% of patients with primary sclerosing cholangitis have inflammatory bowel disease. They can have symptoms, we talked about this before, fatigue, jaundice, pruritus, and upper extremity, right upper extremity quadrant pain. Increased risk for cholangiocarcinoma. And high-dose ursodeoxycholic acid is not recommended is for the treatment of primary sclerosing cholangitis. It can have increased serious events, adverse events, including higher rates for death. That's not good. Liver transplant and development of varices. So there are studies which show that it may improve the biochemistry, but these did not translate into better outcomes for the patient. More discussion on primary sclerosing cholangitis. Associated with inflammatory bowel disease, cholangitis. 70% of the patients are male. You're going to say 60 to 80% of patients are going to be men. This is important. Mean age of diagnosis around 40 years. Diagnosis using MRCP, RCP, or possible biopsy. And it can get us to stage. Treatment, there is no approved therapy. No approved therapy. Aimed at treating symptoms and managing complications. Ineffective immunosuppressants, chelator, steroids are ineffective. Liver transplantation is only therapy that can alter the eventual outcome. All right, here we go. What are we looking for? Which is the following is a likely underlying cause of her bone disease. Bone disease, we're talking GI. Why are we talking about bone disease? Chronic corticosteroid use, well, I guess we could have that in GI. Malabsorption of fat-soluble vitamins due to cholestasis. Direct toxic effect of bile acids on the bone. Parathyroid hormone excess. Renal tubular acidosis. Let's go to this question. 54-year-old female with history of pruritus and fatigue is diagnosed with primary biliary cholangitis. Primary biliary cholangitis. She started on ursodeoxycholic acid. And then on her follow-up 1 year, she received reports new onset bone pain and has had a low trauma vertebral fracture. What's a low trauma? High trauma, she's in a motor vehicle accident and has a vertebral fracture. Low trauma, she's kind of like sitting on her chair and just slowly falls over, or somebody touches her, the wind blows and hits her a little bit, and she has a vertebral fracture. That's low trauma. Laboratory studies reveal normal calcium and phosphate, but low 25-hydroxy vitamin D levels. What do we got? Malabsorption of fat-soluble vitamins due to cholestasis. What are we talking about? Primary biliary cholangitis. Primary biliary cholangitis. And let's talk more about primary biliary cholangitis. What are the complications? Now, it's not called primary biliary cirrhosis anymore, primary biliary cholangitis. We're going to have a comparison between these two diseases. We're going to go head-to-head because it gets very confusing, very confusing. And I'm going to give you one tip. You're not going to like the tip, and it will help you remember forever. Clinical features: affects middle-aged women, destruction of the small bile ducts. They can have fatigue, pruritus, increased cholesterol, increased alkaline phosphatase, normal AST, ALT, increased risk for osteoporosis, as we discussed, hypothyroidism, and autoimmune diseases. Deficiency of fat-soluble vitamins. So fat-soluble vitamins would be A, D. Now D is what we're going to use to help with manage our calcium. So this could, long-term, we can have osteoporosis. A, D, E, and K. Cholestasis leads to accumulation of substance that inhibit bony turnover. Malabsorption of fat-soluble vitamin, and we'll have fat-soluble vitamin deficiencies. It can lead to osteoporosis, osteomalacias, and we have to worry about hepatocellular carcinoma. All right, another board review question. What is the most likely appropriate next step in management? Increase the dose of ursodeoxycholic acid, add obeticholic acid, start corticosteroids, discontinue the ursodeoxycholic acid, and start fibrates alone, or refer for liver transplant. All right, so what's the answers? We're going to add obeticholic acid. Obeticholic acid is FDA approved as a second-line therapy for primary biliary cholangitis. And let's go through. Increasing the dose of UDCA is not going to help. Discontinuing is not going to help, and adding fibrates alone is not going to help. We're not quite ready for a liver transplant, and corticosteroids are not going to do anything at all. So let's get over and have a better discussion. Primary biliary cholangitis. How do we establish a diagnosis? Two of the three, must meet two of the three. So biochemical evidence of cholestasis, and this is going to be an elevated ALK phos. Presence of either AMA, which is anti-mitochondrial antibodies. If negative, there can be specific, and you still have a clinical suspicion, primary biliary cholangitis, we would look for SB100 or GP210. And the third thing would be histological evidence of non-suppurative destructive cholangitis and destruction of the interlobular bile ducts if liver biopsy is performed. So one is going to be, briefly, is evidence of cholestasis. Two is presence of AMA. If not, there's a couple specific markers that can be used. And three is having histological evidence. Diagnosis 2 out of 3, as we discussed. Positive antimicrobial antibody is going to have a specificity of 98%. If AMA is negative, but ANA and SMA are positive, we consider autoimmune cholangitis. Liver biopsy, that's going to be our definitive answer. All right, primary biliary cholangitis, treatment. Ursodeoxycholic acid improves symptoms, LFTs, and slows progression. If an inadequate response after 1 year, add colchicine, methotrexate. Cholestyramine for pruritus. Treatment for end-stage biliary cirrhosis would be liver transplant. Obeticholic acid decreases alkaline phos, and you immediately refer these patients for transplant. Patient with primary biliary cholangitis presents with bleeding, increased PTT, you need to give vitamin K. All right, this is where we're going to do the head-to-head showdown. Head-to-head showdown, battle of the stars right here. This is primary biliary cholangitis versus primary sclerosing cholangitis. How are we going to remember the difference? Well, women are going to have a higher preponderance of PBC. And guess what? There's a derogatory word that women are called that begins with a B. I know that you're going to remember what this is, and you're going to be mad at me for it, but guess what? It works. Derogatory term for women, and women get this higher preponderance. That's how we're going to help remember that women get this. You can just look up and ask your mom what that word is if you don't know. And we're going to have intrahepatic bile ducts, more preponderance for women, AMA in 90% of the cases. Mixed portal inflammation with granulomas associated with autoimmune disease and Sjogren's. And we can use this one, PSC, and we can think, guys, of being a derogatory term that starts with an S. That will help us remember that. You can look at that derogatory term in the toilet after you do a number 2. That's what you think of men as S. And yes, I know this is bad. I know this is hurting people's feelings. I'm glad because you'll help remember. You'll hate me, but you'll remember and do well because you're going to have intra and extrahepatic bile duct dilation, more associated with men. P, ANCA, you're going to have portal inflammation and fibrosis with periductal iron skinning, associated with ulcerative colitis, can have cholangiocarcinoma.